Welcome to NSG 229, Study Session 14, Measles. Introduction. In this lecture, you will learn about one of the most common types of disease of the under 5. This is called measles. Most people have at one time or the other experienced measles infection. And for those who are already nursing, you must have seen measles infection affecting your children, neighbors' children, or even your younger siblings. In the process of our discussion, define measles, describe the pathophysiology of measles, identify the signs and symptoms. We will pay attention to the disease occurring in children and occasionally in adults. Explain the management of a child with measles infection, how to prevent its spread, and complications. Learning outcomes. At the end of the study, you should be able to 1. Discuss measles. 2. State recent outbreaks and discuss solutions. Measles. Measles, also known as mobile, English measles, or rubella, not to be confused with rubella, is an infection of the respiratory system caused by a virus, specifically a paramyxovirus of the genus Morbillivirus. Morbilliviruses, like other paramyxoviruses, are enveloped, single-stranded, negative-sense RNA viruses. Symptoms include fever, cough, running nose, red eyes, and a generalized maculopapular erythematous rash. Measles is spread through respiration, contact with fluid from an infected person's nose and mouth, either directly or through aerosol transmission, and is highly contagious. 90% of people without immunity sharing living space with an infected person will catch it. Okokere International, 2009. An asymptomatic incubation period occurs 9 to 12 days from initial exposure. The period of infectivity has not been definitely established, some saying it lasts from 2 to 4 days prior until 2 to 5 days following the onset of the rash, that is, 4 to 9 days infectivity in total, whereas others say it lasts from 2 to 4 days prior until the complete disappearance of the rash. Pochvelvi and Vanita, 2012. Measles is best known for causing a rash in childhood, but can affect other parts of the body and sometimes occurs in adults. Vaccination has significantly reduced the number of cases, although isolated outbreaks continue to occur. There are 2 types of measles, each caused by a different virus. Although both produce rash and fever, they are really different. The rubella virus causes red measles, also known as ad measles or just measles. Although most people recover without problems, rubella can lead to complications like pneumonia or encephalitis. The rubella virus causes German measles, also known as 3-day measles. However, this virus can cause significant birth defects if an infected pregnant woman passes the virus to her fetus in utero. Pathophysiology. Droplets released from an infected person enter the body via the upper respiratory tract or conjunctiva. The organism then spreads to the immediate lymph nodes and destroys them. This causes destruction of the lymphocytes. This can be referred to as primary viremia. At the second stage, the skin is affected, thus causing the rash symptoms. Complete spot is obvious. Infective period is between 2 to 4 days of the manifestation of the rash. Signs and symptoms. The following are the signs and symptoms of pathophysiology. 1. Fever. 2. Cough. 3. Running nose. 4. Red eyes. 5. Generalized maculopapular erythematous rash. 6. Complique spots in the mucous membranes of the mouth. Causes. Measles is caused by the measles virus, a single-stranded, negative-sense enveloped RNA virus of the genus Morbillivirus within the family Paramyxoviridae. Humans are the natural host of the virus. No animal reservoirs are known to exist. This highly contagious virus is spread by coughing and sneezing via close personal contact or direct contact with secretions. It has an incubation period of 8 to 15 days. Risk factors for measles virus infection. A. Children with immunodeficiency due to HIV or AIDS, leukemia, alkylating agent, or corticosteroid therapy, regardless of immunization status. B. Travel to areas where measles is endemic or contact with travelers to endemic areas. C. Infants who lose passive antibody before the age of routine immunization. D. Malnutrition. E. Underlying immunodeficiency. F. Pregnancy. G. Vitamin A deficiency. Five. In patients where phlebotomy is not possible, saliva can be collected for salivary measles-specific IgA testing. 6. Positive contact with other patients known to have measles has strong epidemiological evidence to the diagnosis. The contact with any infected person in any way, including semen through sex, saliva, or mucus, can cause infection. Treatment. There is no specific treatment for measles. Most patients with uncomplicated measles will recover with rest and supportive treatment. It is, however, important to seek medical advice if the patient becomes more unwell, as they may be developing complications. All other treatment addresses symptoms with ibuprofen or acetaminophen, paracetamol to reduce fever and pain, and if required, a fast-acting bronchodilator for cough. The use of vitamin A in treatment has been investigated. A systemic review of trials into its use found no significant reduction in overall mortality, but it did reduce mortality in children aged less than 2 years. Prognosis. The vast majority of patients survive measles, though in some cases complications may occur, which may include bronchitis, and in about 1 in 140,000 cases, panencephalitis, which is usually fatal. The patients may spread the disease to an immune-compromised patient, for whom the risk of death is much higher due to complications such as giant cell pneumonia. Acute measles encephalitis is another serious risk of measles virus infection. It typically occurs 2 days to 1 week after the breakout of the measles exanthema and begins with very high fever, severe headache, convulsions, and altered mentation. The patient may become comatose, and death or brain injury may occur. Prevention. The following are ways of preventing measles. In developed countries, most children are immunized against measles by the age of 18 months, generally as part of a 3-part MMR vaccine: measles, mumps, and rubella. The vaccination is generally not given earlier than this because children younger than 14 months usually retain anti-measles immunoglobulins antibodies transmitted from the mother during pregnancy. The vaccine should be given whether the child is HIV infected or not. The vaccine is less effective in HIV-infected infants, but the risk of adverse reactions is low. Measles vaccination programs are often used to deliver other child health interventions as well, such as bed nets to protect against malaria, anti-parasite medicine, and vitamin A supplements, and so contributes to the reduction of child deaths from other causes. Unvaccinated populations are at risk for the disease. Traditionally, low vaccination rates in northern Nigeria dropped further in the early 2000s when radical preachers promoted a rumor that polio vaccines were a Western plot to sterilize Muslims and infect them with HIV. The number of cases of measles rose significantly and hundreds of children died. Measles in pregnancy. The most feared complications of measles in pregnancy are congenital abnormalities, which occurs when an infected pregnant woman passes the virus to the fetus in utero. Among other problems are, however, the risk of transmission is highest early in pregnancy. The virus may also cause miscarriage and stillbirth. Recent outbreaks. Since the beginning of September 2009, Johannesburg, a city in Gauteng, South Africa, reported about 48 cases of measles. Soon after the outbreak, the government ordered all children to be vaccinated. Vaccination programs were then initiated in all schools, and parents of young children were advised to have them vaccinated. Many people were not willing to have the vaccination done, as it is believed to be unsafe and ineffective. The health department assured the public that their program was indeed safe. Speculation arose as to whether or not new needles were being used. By mid-October, there were at least 940 recorded cases and 4 deaths. On February 19, 2009, 505 measles cases were reported in 12 provinces in northern Vietnam, with Hanoi accounting for 160 cases. A high rate of complications, including meningitis and encephalitis, has worried health workers, and the US CDC recommended all travelers be immune to measles. On 1st April 2009, the disease broke out in 2 schools in North Wales, Yesgol, John Bright, and Yesgol, Ford, Dalfrin. 2 schools in Wales have had the outbreak and are making sure every pupil has had the measles vaccine. In 2007, a large outbreak in Japan caused a number of universities and other institutions to close in an attempt to contain the disease. Approximately 1,000 cases of the disease were reported in Israel between August 2007 and May 2008, in sharp contrast to just some dozen cases the year before. Many children in ultra-Orthodox Jewish communities were affected due to low vaccination coverage. As of 2008, the disease is endemic in the United Kingdom, with 1,217 cases diagnosed in 2008, and epidemics have been reported in Austria, Italy, and Switzerland. In March 2010, the Philippines declared an epidemic due to the continuously rising cases of measles. As of May 2011, over 17,000 cases of measles have so far been reported from France between January 2008 and April 2011. Where 40 separate importations from the European region had been reported between January 1 and May 20. As of July 2011, 1,145 children have died of 115,600 cases in the DRC, which is also battling deadly outbreaks of cholera and polio. In August 2011, an outbreak in New Zealand has seen 94 confirmed cases in Auckland alone. In November 2011, an outbreak was reported in Canberra, the capital city of Australia, with at least 12 reported cases. In February 2012, an outbreak was registered in St. Petersburg with 87 cases. In February 2012, an outbreak was declared in Liverpool, UK, with 48 cases. Complications. Complications with measles are relatively common, ranging from relatively mild and less serious. Complications are usually more severe in adults who catch the virus. On the other hand, complications of measles are frequent and include A. Superimposed bacterial hair infection, otitis media. B. Pneumonia. C. Primary measles lung infection. D. Encephalitis, rare. E. Measles virus can invade various organ systems and cause hepatitis, appendicitis, and gangrene of the extremities. F. Diarrhea. G. Corneal laceration leading to corneal scarring. H. Subcutaneous sclerosing panencephalitis, rare. Nursing management. 1. History taking. 2. Physical examination. 3. Psychotherapy. 4. Isolation, barrier nursing. Summary. During this session, we have examined measles, also known as mobile, English measles, or rubella, not to be confused with rubella, is an infection of the respiratory system caused by a virus, specifically a paramyxovirus of the genus Mobilivirus. Mobiliviruses, like other paramyxoviruses, are enveloped single-stranded, negative-sense RNA viruses. Symptoms include fever, cough, runny nose, red eyes, and a generalized maculopapular erythematous rash. Measles is spread through respiration, contact with fluids from an infected person's nose and mouth, either directly or through aerosol transmission, and is highly contagious. 90% of people without immunity sharing living space with an infected person will catch it. Okuke International, 2009. An asymptomatic incubation period occurs 9 to 12 days from initial exposure. We also examined pathophysiology, its signs and symptoms, its causes, diagnosis, treatment, prognosis, prevention, not leaving out measles in pregnancy, and so on. End of study session 14. Thanks for listening.